Good evening and welcome to I'm Chris Parnell.
Reporting from Moscow.
Tbilisi.
Times Square.
May your dreams be your only boundaries in life.
I'm Rebecca Cullison, sitting in for William Kinley. Today we're talking about anesthesia, what it is, how it works, and a move towards enhanced recovery after surgery, which includes a new approach to anesthesia for some surgeries. Joining me today to tell us everything we need to know about anesthesia is Dr. Morris Kent with the Medical Anesthesia Group. Thank you for being here today, Dr. Kent.
Thank you for having me.
Tell us a little bit about your background and how long you've been administering anesthesia.
I have been in private practice here in Memphis for 24 years, and prior to that I trained in anesthesia both at UT and at Emory in Atlanta.
Great. Tell us, we've all heard about being put to sleep before surgery, but what exactly is anesthesia?
Anesthesia is the administration of medication to prevent pain, and that can be from a variety of techniques, both injectable drugs and inhaled drugs. And it can be painful procedures in the operating room or in other parts of the hospital as well.
Mm-hmm. So what are those different types of anesthesia? I know I've heard about pain blocks and epidurals. What are the different types?
Well, we try to tailor the anesthetic to the patient's needs and to the procedure that they're undergoing. You might start and think about local anesthesia. If a patient's just having a small surgery, frequently either the surgeon or the anesthesiologist can administer a local anesthetic, and it would just block the sensation of pain just at the site where the procedure is being performed. For more larger operations, say if it's on an arm or leg, we might choose to inject local anesthetic around the nerves that go to that extremity, and just make that extremity go to sleep. If it's a lower part of the body, sometimes we can administer a spinal anesthetic, and just the lower part of the body would go to sleep. And then oftentimes for ladies having childbirth, we'll administer an epidural anesthetic, and that will provide a very comfortable childbirth environment. Then for larger operations, if a patient's going to have a larger operation of an extended time frame, we do a general anesthetic.
Right. What should a patient expect when they are to receive anesthesia?
Well, they'll come to the hospital or be interviewed by a registered nurse, and some of their history will be taken. And depending on their overall state of health, they may be ready to go, or they may need to see their internal medicine doctor to make sure that any chronic medical condition that they may have is under optimal control. For instance, if they have diabetes or high blood pressure, we certainly want that condition to be optimally controlled. Then on the day of surgery, they would come in and be greeted by the anesthesiologist and be interviewed and just review their chart and be sure that everything is in order and the patient's ready to undergo the surgery and the anesthetic. They'll be given a sedative prior to going to the operating room, and then an IV would be started, and appropriate monitors would be placed, and then the particular anesthetic would be conducted.
Okay. So the patient may need to come into the hospital prior to the day of surgery to review and make sure they're ready to go?
Depending on their overall state of health
Okay.
and what have you. Mhm.
Okay. And they may need to go back and see a cardiologist or someone else to clear.
If that's deemed necessary by the anesthesiologist that reviews the patient's history.
Right, right. How safe would you say today that anesthesia is for patients?
Anesthesia is very safe today. The monitoring, the newer monitoring devices that we have has made anesthesia very, very safe. More importantly is the overall state of the patient's health and the particular surgery that they're undergoing. Those are higher risk variables than the anesthetic actually. We are doing bigger operations on sicker patients, so when you start going into those sorts of areas, the margin of safety is not quite as much as it is on a healthy patient for a small operation. So it really, overall, very safe, but depends a little bit on the overall state of the patient's health and the general procedure that they're undergoing.
For your patients as an anesthesiologist, what are the things that you would want them to know prior to coming in for their procedure?
Well, I like for patients to understand that this is a stressful time in their life, and they really need to prepare themselves for an event. I mean, it's like if someone was going to prepare for a half marathon, they'd go out and train for it. And I like to think about patients preparing. You know, if they're smoking cigarettes, they really benefit from stop smoking a few weeks prior to surgery. That smoking puts all sorts of bad vapors into your body, carbon monoxide, and you can actually reduce the levels of those things if you stop smoking. If you're doing any sort of an exercise program, definitely continue that, and if you're not, it'd be really important to start a walking regimen. It'll improve your stamina, and also you need to have the proper mindset and realize that you're an active participant in your care, and you're not just coming in to be taken care of, but to be an active participant in your care and you're getting well processed.
Right, right. Those are great helpful hints. I know patients sometimes who have conditions like sleep apnea, or they need to be sure to let their caregivers know prior to
Right, and bring their if they use the CPAP machine, bring that with them to the hospital, and definitely use the CPAP machine prior to surgery. That can help with their preparedness for surgery.
Great, great. Well, it's time for a quick break. Coming up, typically it's no food before surgery, but a new set of protocols is changing that for some surgeries. Learn more about this approach in just a minute. We'll be right back.
I see trees of green, red roses too. I see them bloom for me and you, and I think to myself, what a wonderful world. Oh, yeah.
GHS-TV has a new website. You can now view any of our shows on our new media pages. Or check out the latest Wake Up Germantown or Red Devil postgame. As always, we're streaming live 24/7. Just visit ghstv.org today.
Make a difference. Pass it on. A message from the Foundation for a Better Life.
Welcome back. Dr. Morris Kent with Medical Anesthesia Group is here to tell us all about enhanced recovery after surgery. ERAS is a set of protocols that takes a different approach to the entire surgery process. So Dr. Kent, tell us a little bit, what is enhanced recovery after surgery?
The enhanced recovery after surgery is a protocol that takes an entirely new way of looking at a patient's surgical care and their entire perioperative process.
Mm-hmm.
You know, it's surprising, but a lot of the care that is administered both in the anesthesia and in surgery is done because that's the way we've always done it. It's tradition-based care. And the Enhanced Recovery After Surgery protocol emphasizes evidence-based medicine. And anything that we do, we evaluate that particular care line and decide are we doing this because it's the best care, or are we doing this because that's the way we've always done it? And we try to really make all of our care evidence-based. In addition to that, the Enhanced Recovery After Surgery protocol it addresses the entire perioperative course from the time the surgery is scheduled until they come to the hospital, and during the time of the surgery itself, and then also in their postoperative care. And it's a team approach. The pre-op registered nurse, the surgeon, the anesthesia team, and the nurses on the floor, the physical therapy, the pharmacy. It's an entire team approach to delivering care, and it has really worked well.
I've heard great results from the process. What sparked your interest to want to champion this?
Well, 2 years ago, I went to an anesthesia meeting in Orlando, Florida, and that meeting was hosted by the anesthesia department for Duke University. And I met Dr. Tim Miller there and learned about the ERAS protocol. The things I learned just made all sorts of sense to me. I thought, why are we not doing this? After that, I went to another meeting in California at University of California at Irvine, and learned more about the program. And I also attended a course at the University of Virginia in Charlottesville, Virginia, and learned more about the course. And it just made a lot of sense to me that was a really good way to deliver care. And I saw some patients in the hospital that I felt like their care and their hospital course could really be helped if we instituted this protocol.
And you actually went to Duke too to learn
Well,
more.
actually, I didn't go to Duke, but the Duke attachment is just from the course that I went to in Orlando.
I see.
I've had the Tim Miller, who's the anesthesiologist at Duke, that's leading this. I've had him here twice to speak.
So they've definitely been directly involved in
Absolutely.
our training. Talk a little bit about, you mentioned that it's a multidisciplinary approach. What are some of the things that are different about this process?
Well, preoperatively, the patient is scheduled to have a particular procedure, usually a major abdominal operation by the surgeon, and the surgeon will schedule the case with the ERAS protocol. Then when that patient comes to our PAW clinic where they get their pre-anesthesia evaluation, the registered nurse there will start the Enhanced Recovery After Surgery protocol. She'll educate the patient of the things that I mentioned earlier as far as starting an exercise routine and stopping smoking and some of those things. But also what we like to do for the ERAS protocol is an epidural to administer the pain relief. And she'll explain to them what the epidural is all about and to expect that. Also, she will encourage them to start a little bit of a nutrition program. We've learned that if patients boost their nutrition prior to coming to the operating room or having surgery, they can reduce their infection rate and improve their healing. Also, we've known for a long time, folks that are long-distance runners have known for a long time the last thing they want to do prior to an endurance event is starve themselves, which is traditionally that's what we do prior to surgery. Well, with the ERAS protocol, we actually give them a carbohydrate beverage to have prior to surgery. It's kind of like the endurance runner doing the carbohydrate load. And that has been shown to be a very important part of the ERAS protocol. So then when the patient comes to the operating room or to the hospital the day of surgery, we'll start the epidural prior to surgery, and we'll also use a multimodal approach to their pain medicine. We don't just start people on narcotics. Traditionally, patients having major operations, their pain will be controlled with narcotics. We try to avoid narcotics as much as we can. Narcotics in small doses are great, but if you try and take care of all of your discomfort with narcotics, that you get into all the side effects, nausea, vomiting, constipation, and those sorts of things. And so we really try to avoid that. And then we do what we call goal-directed fluid therapy, which is one of the very important parts of the protocol, and that is we carefully monitor how much IV fluid we give the patient so that we don't give too much, we don't give too little. It's kind of like Goldilocks. We want to be just in that just right area. Then post-operatively, the surgeons actually start the patient's diet much earlier than traditionally. We found that even after major abdominal surgery, patients can get a liquid diet started either the night of surgery or the morning after surgery, and that will really improve their healing and their ability to get well. We also get patients out of bed. The patients that do best with this get out of bed the night of surgery. The more they can get up and start walking, the faster they'll get well. So our nurses, the nurses up on the 4 West there at Methodist are really good about doing that. And then we follow the body weight. We've learned by evidence that if we can keep the patient in a normal volume state, that they'll have the fewest amount of complications. And we follow that by their body weight. If patients start getting excessive body weight after surgery, then we know that they're getting too much fluid, and we'll turn their IV fluid down. As soon as they start taking a nice diet and they're taking their diet properly, we try to stop the IV fluid altogether.
Which surgeries are we using this on now? I know it's not everything at this point.
Right. The surgery that really works best for it at this point is a colon resection, something like that, a major abdominal surgery. We're also doing it for upper abdominal surgery, the Whipple surgery and the liver surgery and some of those operations. It definitely helps those operations. Any major abdominal surgery will benefit from this.
Okay. And how are the patients responding?
Oh, they love it. I had one patient who had previously had major abdominal surgery with the traditional care.
Yes.
And she had to come back for another operation, and she had it with the ERAS protocol, and she just went on and on about, why didn't you do this for me last time? This has been so much better. I don't know if you've ever had to take narcotics for anything, but I remember as a child, and that's one of the things that spoke to me about this. I had my wisdom teeth removed, and the dentist gave me a prescription for a Percocet, and I took some Percocet, but I was still having pain. So I took some more Percocet, and it wasn't relieving the pain, so I took some more Percocet. Eventually I still had pain, but I was nauseated and I felt terrible, and that's what we'd really try to avoid. We want to relieve the pain with a regional anesthetic like the epidural or nerve block, but not with the narcotics.
Right. Great. Up next, Dr. Kent talks about the future of enhanced recovery after surgery.
Okay, Josh, do your stuff.
Okay, people, you know the drill. Canned foods only, guys.
Sometimes you gotta live what you believe, open your arms, 'cause that's where it starts. Right here with you and with me. What the world needs now is love.
Generosity, pass it on.
A little help from up above. Faith to me.
A message from the Foundation for a Better Life.
GHS-TV has a new website. You can now view any of our shows on our new media pages. check out the latest Wake Up Germantown or Red Devil postgame. As always, we're streaming live 24/7. Just visit GHS-TV.org today.
You may say I'm a dreamer, but I'm not the only one. I hope someday you'll join us, and the world will live as one.
Jessica, we need to leave right now.
I need to get something. Dance recitals are so boring.
There's a meaning no one knows, waiting to be set
So,
free.
what's the empty suitcase for?
The grand prize trophy.
Duh.
Confidence. Pass it on.
I was born to be somebody.
Kent with Medical Anesthesia Group is with us today, and we're talking about enhanced recovery after surgery. Well, Dr. Kent, we were talking about the ERAS program and the benefits to the patient. Can you talk a little bit more about, do these patients stay in the hospital as long as they did with previous protocols, or what are you seeing with the ERAS patients?
You know, it's amazing, but we've done an in-house study with this protocol for about the last 14 months, and patients that have a majority of the protocol complied with are going home in about 4 to 4.5 days. And patients that have traditional care for the same procedure are staying in the hospital about 9 days.
Wow.
So we have significantly reduced the patient's hospital stay, which is great because you know, if you have an illness that interrupts your life, I know when that's happened to me, the first thing in my mind is, when can I get back to my normal life?
Yes.
And so I really am happy that that we can do that for folks.
Absolutely. Other complications, are we seeing reduced complications with this method?
We are. The Enhanced Recovery After Surgery protocol has been shown in literature to significantly reduce complication rates. The amazing thing is, if you properly control patients' IV fluid and their body weight, as the body weight's a reflection of how much IV fluid they've gotten and what their fluid status is. If that is properly controlled and they're normal, if they have a normal volume, normal body fluid volume, their infection rate, the wound infection rate, has been shown to be reduced by 50%, which is huge. And I know I was mentioning this to someone, and they said, you know, we do better if we don't give as much care. And that, I think that's exciting. Also, one thing we've really noticed is that patients who are otherwise fairly healthy, and they come to the hospital, come to the operating room for major operations, if they get too much fluid, a lot of that fluid just settles in their lungs, and it results in them needing to be on a ventilator after surgery, which is a terrible thing to do to a normally healthy person. So we find that if we can give just the right amount of fluid, not too much, not too little, we don't need that ventilator stay, which is, you know, that can lead to all sorts of other complications, pulmonary infections and what have you.
Sure. How many patients at Methodist Germantown do you think have benefited from this?
In our study, we've got 40 patients, and that was over the last 14 months. But those are just the colon resections that we've followed, because those are the only patients that we followed. But more than there's significantly more than that have been in the study or on the protocol and have benefited from it.
Okay, are you continuing the study?
We are.
Long term, see the benefits of. Great, that's great. Where do you see? I know we're doing the colon surgeries and abdominal surgeries. Do you see us adding additional surgeries in the future?
I think any surgery, any patient that has to have a prolonged operation would benefit from the goal-directed fluid therapy that I've mentioned. So especially if the patient is sicker, an elderly patient who might have a weak heart or weak lungs would dramatically benefit from this method of fluid therapy and being sure that we don't give too much fluid. You know, I heard Dr. Henrik Kellett, he's sort of the founder of this, and he's a professor of surgery from Copenhagen, Denmark. And I spoke to him when I was in California. He tells me they've been doing this in Denmark for over 15 years. So while the ERAS, it's new to the United States, it's really not new.
Right.
But any patient who needs careful fluid administration would benefit from this. Dr. Kellett says that since the Korean War, we've looked at IV fluid as vitamins. You know, when one bottle of fluid goes down, another one comes up, and without a lot of thought behind it, and we're really challenging that, and that's one of the major benefits for folks having surgery, is if we are very careful with the fluid that we administer.
Sure, it makes sense. Where do you see this going in the future?
Again, I think that anyone coming for a major operation who's a little bit sick, has a weak heart or weak lungs, would dramatically benefit from this protocol. This is something that we're expanding it into the University Hospital downtown, and the hospitals that I mentioned to you a minute ago, University of Virginia, University of California, Irvine, Duke, major centers around the country are fully embracing this protocol. Reduces cost to deliver care, and it reduces the interruption in patients' lives when they have to have surgery.
Right. Sounds like it's good for everybody.
Yeah, it is. It's a win-win.
It really is. Well, thank you, Dr. Kent.
Thank you.
This has been just very informative, and I appreciate the work you're doing to benefit the patients at the hospital.
Thank you.
Great. That wraps up our show for today. I hope that living well will help you and your family lead healthy lives. Thank you for watching.